Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our guest speaker tonight is Dr. Harvey Richman. We're very fortunate to have him. He's a graduate of the New England College of Optometry, where his education emphasized evaluation of children with behavioral and perceptual difficulties. He has got a tremendous amount of accomplishment in pediatrics and billing and coding. So we're going to hit the highlights here. In 1997, he was a Young Optometrist of the Year in New Jersey. In October 2007, he was awarded Optometrist of the Year in New Jersey. He was president of the New Jersey Society of Optometric Physicians from 2008 to 2009. And he is recognized with the New Jersey Society of Optometric Physicians Lifetime Achievement Awards. He has been involved in the American Optometric Association third-party committee to work on coding, and he has really accomplished a lot in this field. So with that, please welcome virtually Dr. Harvey Richman. Harvey, take it away.
Thank you very much, Joe, Greg, Vanessa, and everybody else getting on tonight. So again, what we'll do, we're going to kind of go through, we have a whole bunch of slides. I'm going to try and make this as interactive as possible. If there's questions, feel free to send them over to Greg or Joe, and they'll kind of interrupt me as we go along. All right, let's get this going. So first, all disclaimers. Everything I'm giving you today is current as of today. Things can change tomorrow. We never know what CMS is going to do, but I'm going to give you the information based on CPT and some other things. Disclosures, legitimately, I write for several different publications. I am a paid consultant for Right Eye, which is an eye movement test device, and Barty EMR. That being said, there are no financial relationships with anything we're going to be talking about tonight. So again, starting off with ICD-10, as far as changes for this year, really not too much. You know, when it came to eye stuff for optometry, let's see if we can get this to go there. There we go. Good. The primary thing that I want everybody to remember is when the H codes, the I codes that everybody, and I use I-E-Y-E, not the letter I, all the H codes that we use, there were no changes for ICD-10 in 2023. That's pretty cool to say because usually every year there is. We try through our coding committee, we are actually directly in communication with the CDC and make recommendations for new codes to be coming out. Make modifications, and if there are any specific codes, speaking of which, if there's any codes that you guys think we should be having, please feel free to send that over in a chat, and maybe we'll try and get that over to CDC. We're working on some other things right now for the next year coming up in the future, but right now, nothing on that one. Yippee. There are some additional codes that were changed, though. Previously, injectable non-insulin diabetic codes, we were advised to use the Z79.999, which was the same one as the long-term medication uses. They created a new one this year for Z79.85. The other ones, which were previous, were the Z7984 and Z79.4 orals and insulin use, but they did create this new code. That means that when you are having patients that are using a product like Ozempic and other similar types of injectables, that you should be using that code on your claims. If you are using the old codes, you'll still get your claims paid, but you are supposed to be using those at this point. We've been running into a problem with a lot of the EMRs didn't even pay attention to these changes last year when they made them. We're still running into that this year, that we're discussing this with a lot of the, again, the EMRs, understanding that there was a change for that. So just, again, be aware of it when you're doing it. Another one, a new code was Z79.69, long-term use of other immunomodulators. Again, it's basically, these are for your patients that are using Humira, methotrexate, Remicade, those types of medications, when they may have ocular side effects. You may need to be able to document this. You may need to be doing a visual field, or you may be doing whatever, dry eye assessment, whatever it may be. And when you have those in there, you'll put this as a secondary code on that. You'll put your primary diagnosis being dry eye or visual field defect or whatever it is. And then you'll put down the utilization of the medication on the second component. That was it for ICD-10. Pretty easy this year.
Hey, Harvey, can I just ask a question? Because it just happened to me today. I had
Absolutely.
A patient come in on Dupixent, and it creates like a conjunctivitis.
Yes.
And should I have used that code whenever treating that patient and doing the follow-up?
So the answer would be, again, you're going to put did the patient, well, first, I guess the question is, did the patient have conjunctivitis when you saw them or not?
Today they did. They had the side effect from
Okay,
the
fine.
Dupixent.
So you put down your E&M or whatever level service code that you do, then you put down your conjunctivitis, and then you now have A, B, C, D, E, all the different options for your ICD-10 code. You would then put down the Z79.69 also. Now, again, it's not going to have any bearing on your payment. Zero. You understand that. These are primarily for documentation purposes. Insurance companies like to track it at this point. Some of the oh my God, workman comp kinds of claims and things like that, or Medicaid claims sometimes also require the additional information. It is guidance from ICD-10 to use them. That being said, the payers really aren't paying much of attention. So back to answer your question, Greg, yeah, you should do it if it's appropriate. Okay.
Perfect. Thanks. Yeah, that's
Got
great.
it.
Yep. Thanks.
Absolutely. All right, let's go to the next one here. Okay, so when it comes to CPT, with changes there's not an awful lot that, I mean, there are going to be some things on here. Just a quick thing. I started in the beginning, showed you, I made it with some input from Rebecca. Rebecca's the, well, not the woman that I'm holding. The woman I'm holding, that's my wife, Maria Richman. Rebecca's on the side there, and then Doug Morrow. We are the AOA's coding team that goes to CPT. We sit down at the table and discuss all these codes that go out there. In 2023, there were 393 editorial changes. There were 225 codes. Now, again, these are not all optometry. Luckily for us, or else we'd be here for 3 days discussing all of this. There were a bunch of deletions. The primary stuff that we're going to talk about today are E&M codes, some changes that occurred with the E&M codes, as well as some of the other services that are specific to optometry as we go along. So, Greg, I think we're going to do the first poll, if we can get this one up here. Okay, so on poll one, what I'm going to do here first, before you answer here, I'm going to give, I realized after I made the poll and I gave it to Greg, I made a mistake on question C, or answer C. The third one is incorrect. I will tell you, do not pick C, okay? Because I just typed it in wrong. So when referencing E&M medical decision-making, which is correct choice? The physician must complete a diagnostic test account. Major surgery is defined by the global period. A stable acute illness is classified, it should have said moderate complexity, or prolonged service time begins after the level 5 time threshold. So those would be those are the questions. So it's 1, 2, 3, or 4. When I do my questions, I'm going to kind of do them before I'm going to answer them. So we'll kind of get an idea of whether or not you understand the premise here. You may not know these because some of this stuff, actually, most of this stuff is new to what's happened in 2023. So unless you're sitting around, instead of reading Sports Illustrated or whatever else you like to read, Vogue magazine, you happen to be reading the CPT book, you may not know these answers just yet. Some of the stuff later on we'll get a little bit more lax on.
All right. So Harvey, I'm got about a pretty good percentage here. I will end it in a minute or in a few seconds.
I got it.
And making it live and interactive. Okay, so I'm gonna end the poll, save some time, share the results, and there you go.
So we again, there were 4 answers, and even though I told somebody not to answer C, we got a couple people that did apparently. So the first answer is physician must complete diagnostic test account. Unfortunately, that is not correct. And I'm going to show you that is a change. The next one is major surgery is defined by the global period. Again, unfortunately, that's incorrect because that changed. Those two used to be in the previous 2 years of documentation for E&M, which was 2021 and 2022. For 2023, these were changed. The third one I said, actually, what would have been is if a stable acute illness is classified low complexity. We'll show you now in a few moments. But that was the incorrect one because I told you that. But the true one, which really has not changed, is prolonged service time begins after the level time 5 threshold. So we'll talk about that. That is the correct answer. Let's go along here. So let's talk about where they're talking about in the E&M evaluation management introductory guidelines. So this is new information in here. So ordering a test may include those considered but not selected after shared decision-making. So what it was is, if you had a patient, let's say you had a patient who you really need to do a visual field for, but they couldn't sit still enough. Either they have, I think of different things I've had in my office. Jaw cancer, they couldn't put their chin on the chin rest. Severe tremors for Parkinson's, they couldn't put their chin on the chin rest. Some situation like that, where you need to have them in those situations, but they aren't able to do that, that would be a reason that you may recommend it, but you're not actually able to do it. As long as you can document why you're not doing it is appropriate. Also, a patient may ask for a specific test that isn't necessary to condition. Again, patient may say, I want to have an MRI or I want to have a CAT scan because I have a headache. And you see that they have a convergence insufficiency, or they've got, so you decide that there's just no medical reason for it. Again, documenting that this is something that was discussed with the patient does count as part of your risk management decision-making for MDM, medical decision-making for the ordering tests in 2023. So again, do not need to do that anymore. They have to be documented. That's the key aspect. Put it in the chart. Okay, again, for 2 years, this was just up in the air. This whole discussion about surgery being major or minor, and originally the discussion, which was not by CMS or by CPT, it was really by people like me and everybody else that was out there trying to figure this out, because there was no definitive component. And we said, okay, it's minor surgery if it's 10 days or less. It's major surgery if it's 30 days or more, those types of procedures. Well, CPT came out and said these terms are not defined by the surgical classification as far as timing. It's based on, it's a very vague answer. It's basically what the doctor feels is minor or major. Basically saying that a cataract surgery may not be a major component. It may be minor. If somebody does 40 cataracts a day and it's a secondhand thing to them, then it's no big deal. Or if it's somebody who, has a very complex case, then it could be a major one. Same conversation talking about elective or emergency. They made the modification in there was based on the timing of the procedure. Okay, when the timing is. If the patient can be planned in advance, it's elective. If it's emergent, mean they have to do it at that point, whether it's, going to be weeks down the road or 48 hours down the road, but they can be minor or major. And then the other aspect, looking at risk factors with it, those are relevant to the patient and procedure, specific to that specific patient and that specific procedure. There are risk-based calculators that are used, but they're not required in assessing the patient and provide procedure to risk. So again, it's just really kind of figuring out that what CPT is trying to give us much more flexibility. That was the whole purpose in the new EDM guidelines, was not to make things more difficult, but to give us more flexibility. Document why you have a problem, why the patient needs to have, such type of procedure, be it punctal plugs or, a corneal scrape, whatever it may be. That could be, I could consider if there's a situation where the cornea is peeling off because of a burn or something, that would be an emergency surgical procedure at that point. This is the one that I made the boo-boo on. So on this one, we're going to show here that in 2023, actually the part on the left-hand side, which says number and complexity of problems addressed, low, the first three things there, that was 2021 and 2022. In 2023, they added that in the low complexity, a stable acute illness or an acute uncomplicated illness or injury requiring hospitalization or observational level care will be considered low. I guess I really thought that those would have been moderate, but when they looked at the risk factors and the number of issues, that they felt that was going to be okay. To me, if a patient breaks a leg or has to go to the hospital because for whatever reason, by the time you're sending a patient to a hospital, if it's acute, I would assume that there's and they're going to be an inpatient, I would assume that would be a little bit more complex. I can't decide, I can't change these things. That's what's out there, but just be aware of those are what's happening for the 2023. Again, remember the consultations still do exist. The 99242, 43, 44, and 45 still exist. Now, Medicare doesn't cover them. but some of the other carriers, United Healthcare does still recognize them. Some of the other carriers still do recognize the consultation codes. Because of the changes to E&M, we actually, the CPT came out and said that they were eliminating 99241 because of the time factor as well as the medical decision-making. By the time you had to get to that, you have to have a straightforward, it would actually be a level 2. And that's similar to the why 99201, the new office patient low got retired last year. So again, just things that you're aware of here. Not that you're doing an awful lot of consultation, but you should be aware of it. Now, this is the one that that was the correct answer, was prolonged outpatient services. And they actually created a new prolonged inpatient services. So if you happen to be a doctor that's working in a hospital-based setting, you are spending the additional time with the patient, it would be, you would use the 99418. But in order to use the 99417, which is your prolonged service time, you must meet the level 5, be it a 99205 time period first, or the 99215 period first. And I don't have the times up in front of me at this point, but a level 005, a new comprehensive level 5 patient, it's 60 minutes to 74 minutes. Now, it specifically states it's 15 minutes. It's used after the 15 minutes. So you can't do it till you've actually hit 75 minutes. Again, it's 60 to 74 minutes be a level 5 based on time. But if you hit 75 or 77 minutes, you'll build 99417 plus the 99205. You cannot use prolonged time with medical decision-making. It has to be done solely on time in those patients. So again, it was a little convoluted to get to that last one, but that's why I wanted to show you. That one has been there. The other two were new changes there. And again, these are just Medicare codes there. We'll get rid of that. All right, so let's talk about some category 1 CPT, not E&M services that are changes specific to optometry/ophthalmology, the special ophthalmologic services. So again, just to remind everybody, last year, 92065, which anybody who's over, I guess, 1 year out of school would have learned that 92065 was defined as orthoptic and/or pleoptic training with continuing medical direction and evaluation. Last year, they removed much of that and just defined it as orthoptic training. And they did it because 2 reasons. Number one, pleoptics really weren't being used anymore. It was a type of management that was used back in the 50s and 60s to try and help deal with amblyopia as well as some of the strabismic issues. And then the other aspect that says with continuing medical direction and evaluation. Well, when it states that basically says you're providing an E&M service on top of the orthoptic service. And that isn't the case. There was no other code out there. Actually, there was no other code that had and/or listed anywhere in the CPT book other than the orthoptics and/or pleoptics. And the second part, there was no other code that was in the CPT book that said with continuing management. Okay, so CPT said, no, we can't do this anymore. So they made it and changed it to orthoptic and orthoptic training only. I think the next one is our question. I'm sorry, I didn't give you a heads up on that one, Greg. So the next one is when orthoptics is provided in the office, how can it be billed per day as of 2023? Physician provided 92065 or 92066. Staff only provided 92066. Physician and staff provided 92065 and 92066, or physician and staff provided 92065 and 99211, which is a E&M service given by clinical staff. So again, this is
Harvey,
just,
I'm not sure if you can see the polling questions on your end as kind of a guess, but the poll's up and running. We have about 44% of the people rolled in.
I don't see the numbers up there yet. I trust you. You'll tell me when to do it. Again, what we're going to address in the next few slides is really the changes here, because 92065, this is pretty, it's unique that a code was changed within a matter of 1 year. because 92065 got changed in 2022 and 92065 changed again for 2023. I'm telling you right now, let's work on the next few slides once we say it's okay.
Yeah, I'm going to share it here in a little bit. I think people are thinking about it, trying to figure it out.
Or they're sleeping.
And I'll just end the poll.
Cool.
I'll share the results for you.
Okay. Wow. Okay. So this is going to be really good that we're doing this presentation today, because the people, I assume that I'm the 3% because the correct answer is number 2, which is that that is staff only provided 92066. So let's go and let's close this and let's go to it. And this is kind of interesting. So as I said before, last year, 92065 specifically said orthoptic training. In 2023, they added orthoptic training performed by a physician or other qualified healthcare professional, and a new code was developed, 92066, which was orthoptic training under supervision of a physician or other qualified healthcare professional. Now, what makes a QHP? A qualified healthcare professional. Actually, you know what? We're going to come back to, I'm going to explain that in a second. Let's do this real quickly here. So you cannot, if we go back to the original questions here, I'll go back here. You cannot provide 92065 and 92066 on the same day. I'm going to go back and forth here. It says you cannot report the two in conjunction. Okay. Again, you can't do 92066 with a 92065. The secondary and tertiary codes that are there, the 06870 and 06880 are amblyopia therapies that were developed 2020, I believe. Those are remote amblyopia management. So you can't do those ones. I'm going to go back to the slide again here. So you can't do level the C. If it's physician provided, it has to be 92065. It can't be the 92066. So it has to be one or the other. Since we said staff only provided, then it's 92066. Now, I'm going to jump ahead again. This is it for those of you who do a lot of vision therapy or are more interested in it, an AOA document that I've been working on for the last, I believe, 10 or 11 years. Every year we kind of update it with the new codes. You can go to the AOA website and just kind of download this. It's a lot of pages, but has a lot of information. So here's what I was getting at, is qualified healthcare provider. So people say, you know, what is a qualified healthcare provider? Well, within medicine, within CMS and CPT, a qualified healthcare provider is somebody who is licensed to perform services and can bill independently. Licensed and can bill independently. Very important. So I have down at the bottom of this one, COVT. We've gotten a lot of questions. I actually, besides, you know, as Greg talked about and Joe talked about, I do an awful lot of stuff with AOA. I also do an awful lot of stuff with COVD. So there's been a lot of questions about, well, can a certified optometric vision therapist who is clinical staff bill with a 92065? Because they're qualified, they've been certified, they took a test and did such. The answer is no, because they're not licensed and they can't bill alone. So therefore they do not. Who is a QHP? An occupational therapist, a physical therapist, a speech language pathologist, a psychologist, a chiropractor. Anybody along those lines is considered a qualified healthcare provider. And the other part that I've put in here is general supervision. Because again, when we go back to this, it says under supervision, 92066. So orthoptic training under supervision, that would be a situation where the doctor is supervising the therapist, the clinical staff. They do need to be general supervision. Again, needs to be available for questions, does not need to necessarily physically be in the room, but general supervision does apply on the 92066, but cannot be delegated at all for 92065. Again, a conversation here about direct supervision versus general supervision. This applies also to rehab codes, but we're not going to get into that today. All righty, so let's start moving a little bit forward to some additional stuff that were changed for 2023. A couple years ago, I believe it was 2020 also, there was, maybe it was 2021, there was new code, point of care autonomous analysis and report unilateral, actually it was automated analysis and report. This is imaging of retina detection of monitoring. So this was, I don't know if you guys are familiar, but there's remote care. You actually stick it's a device, almost like a keystone type of device, where you put your face in the camera, it takes a picture, and now instead of being sent off to a remote reviewing facility where either an optometrist, ophthalmologist, or somebody else was reviewing the data, this technology was so highly effective that it was making clinical decisions based strictly on the images that they were getting. So there was a new code developed for it. Well, because there's no physician service, the valuation is not very high. It is not something that that really optometry is using, but this is more what your primary care doctors, your diabetes doctors are going to be using, because again, they can completely bypass all eye doctors, make it easier for them to meet their HEDIS measures, because they're getting the evaluations of the retina at this point. But what they did is they changed, again, the conversation is really, they changed the word autonomous from automated. We're going to talk about Appendix S, which is a new section within CPT, in a few moments. Another new change is 92284, which is the dark adaptation. They added the word diagnostic before it. Why did they do that? Well, in case you haven't known, the primary manufacturer for the dark adaptation devices went bankrupt and then was bought out by another company. When they were going for valuation, they ended up finding that that the device itself was being used in a screening mode primarily and not in a diagnostic mode. So what they did is a CPT based on recommendations from CMS, because of the overutilization and misutilization of the device, change it to say diagnostic. Okay, so when you have a patient that you have already done a screening, you believe that the patient has some type of problem with dark adaptation, that's the only time you're supposed to be using it. I will tell you that the AOA did, when we're sitting at the CPT meeting, did argue the adding of this, because we felt all diagnostic tests are considered diagnostic, whether it's a visual field, a camera, OCT, gonioscopy, they're all diagnostic. The problem was this major up push in utilization, and CMS said, no, we can't let this go. So CMS is trying to get involved with a lot of these things. Again, anterior sclera surgery, they just basically added cantaloplasty in for this procedure, just nothing new. I don't do this type of procedure. I don't think any optometrist can actually do this, but you may work in an ophthalmologic or a surgical facility that uses this. So I just want to have aware of it. And again, that has to do with it. Again, post-operative care still is 20%, just as usual. Now, this one is kind of cool. Autonomic function test. For me, it's kind of cool because I use this in my office on a pretty regular basis, this type of technology. You may have heard of quantitative pupilometry. It was something that was discussed several years ago, and it was a category 3 code, meaning it was a code that was considered investigative or emerging technology. It was on the books for 5 years. It actually sundown, meaning there wasn't enough utilization to document for it. The science was there behind it. So they came out with this new code that said 95919, quantitative pupilometry with physician or other QHP interpretation report, similar as usual, unilateral or bilateral. What is it? It's a rapid, non-invasive measurement of the autonomic system. And I'm going to actually show you. So this is what a pupilometer looks like. It's not measuring the pupil size per se. It's not measuring the pupillary distance. It's actually here. I'm going to show you. This is a video. And what it is it's flashing a light. It's monitoring the size of the pupil, how quickly the constriction is, how quickly the pupil responds back. So it's checking for neurologic conditions such as MS, diabetic changes. I use it an awful lot for my TBI patients. A lot of my traumatic brain injury patients are using it. I use it for whatever reason. I don't know why this is. I see a lot of special patients, more complex patients on the neurologic end. I don't see an awful lot of MS patients, but I see an awful lot of diabetic patients and a lot of TBI. And for those reasons, I use the device pretty regularly in the office. This kid happened to be a TBI. He fell off his scooter without a helmet, or his little, whatever you call it, yeah, whatever those things are. I can't think what they're called right now. The little motorized scooters. He fell off there. So, we use those at this point. So let's go back off to Appendix S. So again, go back. Rapid DX is another product that's out there. I think Conan makes it. That's another option that you can use for the device. It doesn't do the same type of assessment. That's looking for afferent pupillary defects, but it does check for those that doing the same technology for a non-invasive management of autonomic nervous system. Okay, so again, just be aware of that. Okay, so Appendix S, I said I was going to come back to that. So artificial intelligence has actually dramatically changed over the last several years, as you guys are probably well aware. In those aspects, they had to create different categories of artificial intelligence, because when CPT started looking at this information, they were looking at it and saying, okay, artificial intelligence, and they just kind of put it, blanket out there. So they developed 3 different levels. There's assistive, we'll go through assistive, augmentative, and autonomous. Let's go back to assistive. So assistive is basically, the device is actually doing some work and it detects data. That's it. There's no analysis, there's no conclusions, and it requires a physician or other qualified QHP to look at the data and interpret it and report it. Okay, so imagine you have a visual field. Again, I'm visual field at this point. And in those situations, when you have, the patient just sticks in there, if the visual field just did dots and you got the scan and saw just the dots, but no other data was given out of it, that would be a form of assistive in those services at that point, assuming the patient was able to put themselves in there in that scenario. Augmentative is one where the work is performed by the machine and the machine analyzes it and quantifies it in a clinically meaningful way, but it still requires a physician or other QHP interpretation and report. In that situation, that would be more similar to what we do now currently have with OCT, visual fields, different devices which are going to report ERGs, things are going to print out a report where it gives us actual data that looks in it and analyzes, says there's high risk, low risk, progression noted, things along those lines. We still have to do the interpretation. We still have to say, yeah, there's visual field loss, but is it because of glaucoma? Is it because of ischemic optic neuropathy or whatever it may be? So looking at that aspect. The third part is the newer version, which is this autonomous. Now, in this situation, the device is actually interpreting the data, independently creates a decision, and actually gives guidance for treatment protocol. So it's saying, this is what we found, this is what the device says, this is it, and therefore you now are going to do this. There's 3 levels of AI. Again, it becomes convoluted, but that's the way CPT and coding, and obviously the way my brain works, is multiple different levels. And in this situation, there's level 1 within autonomous, which it draws conclusions, offers diagnosis, which are contestable and require the physician to act to implement. Even though the device says this is what you should do, the doctor has to say, okay, hit the button and we're going to do it. Level 2, it actually has it, and it's going to start the protocol, and it allows for the doctor to say, no, you're not going to do it. Level 3, actually, in that situation, the doctor has to stop the procedure or the treatment protocol from happening. So in what's happening right now for the retinal screening that we talked about, it's actually being at the level 2, because the device is coming out, it's saying the patient has diabetic retinopathy or doesn't have diabetic retinopathy, and it's saying at this point you now need to go for injections or laser or whatever it may be. It's telling the person who's running the test what to do. It's not saying you make the decisions. So that's where that goes on that one. Again, it's a little convoluted. Pay attention to this, because every year we are seeing more and more of these artificial intelligent technologies coming to the table when we're sitting there at the CPT discussing these things. Alrighty, so clinical examples. We're going back now a little bit to the E&M services. So previously there was a whole section category or section C or appendix C in the CPT book, which talked about clinical examples. There would be actually examples of what you had to do for an eye exam or for a what do you call it? A podiatry visit or rheumatology visit. There were specific or surgical stuff. There were examples that what would be done for the E&M. And that's what you used to see. This is what you need to do for, the 12 points in order to hit a level 4 for an E&M service on an eye examination. Well, all of those went away because at this point, everything is based on medical decision-making or time. So those went away. Let's talk about some of the things that go on with Medicare. Well, by now you probably have figured out that Part B deductible went to $226 for this year. It went down for the first time in a long time. It was $233 last year. Other ones which are kind of interesting. Medicare telehealth maintained the 92012 and 92014 as being a billable telehealth service. I will tell you, the AOA was opposed to these codes. Part of what happened was we ended up getting that the new eye exam, the 92002 or 92004, at the end of the PHE will go away. But the problem is, in order to do the requirements that are necessary for a level 4, a comprehensive eye exam, we do not have the technology yet to do those components via virtual or telehealth services. That being said, this is what's out there at this point. So those are being removed. Another part is talking about the audio codes. So right now, in the original proposal, they said that they were not going to continue using the audio codes, audio only, which is your telephone services to patient for the telehealth. They said it would expire at the ending of the public health emergency. That being said, thank goodness, the final rule came out, and even though originally they said no, they actually maintained it and left it that they're going to be in there for a 2-year. The budget bill they passed was a 2-year extension past the ending of the public health emergency, which is proposed to be right now mid-May by President Biden. If I remember I don't have the exact date, but it's mid-May at this point is what they're projecting. Other things that you may have been seeing, guess what? As usual, we had a fee schedule cut. I apologize. I can't say anything too much great about that. It's just what happens. 2023, there was another 2% cut. 2024 is a projected 3.5% cut, and sequestration is still in fact. So instead of just having a 2% cut, you're actually seeing potentially a 4% pay reduction. I'm going to throw in, this is stuff we don't need to talk. I'll leave this up here while we talk. But another thing that just I found out personally this year is I do participate with MIPS, which is the Medicare, the incentive program, which used to be PQRI, different, and then it's going to be MVP in the future. So I participate. My docs in our office, all the docs in my office are not eligible because we didn't meet the requirements, the minimum requirements, but I still participated. Well, in 2021, CMS had a little back door, and you may be seeing this on your claims at this point, that if you bill as a group, even if the providers are not eligible, if the group was, they are hitting you with a penalty. So you may be seeing a couple cent reduction on your reimbursements strictly because you billed as a group. If you have multiple doctors in your office, I will tell you again that we, being me representing the AOA and the powers that be in that scenario, are communicating with CMS, because even though they said that they were going to overturn that policy, they still maintained it. So again, it's not part of the slide deck at this point, but just be aware that there are some concerns. And if that is applying to you, please let somebody know within your state so that they can kind of address for you. Other ones you may be aware of, may have been paying attention to, is in December 9th, 2022, the FTC did propose an eyeglass rule, which basically said that the optometrist and ophthalmologist provide a patient a copy of eyeglasses immediately post-refractive eye exam. Well, that's not really anything new. But now you need to get a signed statement from the patient confirming the receipt of the RX. That's kind of like the contact lens rule that we're dealing with. and you had to keep the record of confirmation for 3 years. The good and the bad, well, it basically allows for no third-party seller verification, whereas contact lenses, they have that ability. In glasses, there isn't. There is no requirement to include pupillary distance. There's no requirement to provide additional copies of eyeglass prescriptions to patients. But there is this signed acknowledgement proposal. That's the problem, is you now need to potentially do this. Now, this has not been applicable yet. There was a 60-day comment period. All the organizations, every eye-based entity basically said, no, we're not supporting of this, but that was where we were. All right, so now for something completely different. We're gonna start talking about some eye disease things at this point.
Hold on 1 second here,
Yeah,
Harvey.
well, I
We
was
did
gonna
have
say,
a question roll in.
Please.
We had someone roll in, just said, do you see CMS getting rid of the 92,000 codes in the future?
I sure as heck hope not. The answer is, it's been talked about. I've been involved with this, I guess, 25 years. I've been dealing with the coding and billing aspects of things. And from day one, it was a threat that was coming down. Well, first of all, it wouldn't be CMS, it would be CPT. Okay, I think about that at this point. You know what? I shouldn't say that. CPT maintain the consultation services. This consultation services still exist. CMS doesn't pay for it. So I guess it's possible that CMS could eliminate that. It's a consideration. The answer is I don't believe that it's going to be something. I will tell you, sitting at the table, I have not heard anybody discussing it, even being brought up as far as a concern. There are other services, there are other professions that do have similar types of only within their profession type of services. Unfortunately, the vast majority of those are other qualified healthcare providers. Psychology is a primary one. Physical therapy and occupational therapy have specific OT and PT examinations, which are not E&M services. General ophthalmologic services, the 920, 02, 014, 004, and 01, whatever, when I left out of there. Those do fall under E&M guidelines. So it's highly unlikely. Do I see it? The answer is no. Is it possible? The answer is of course, but everything's, changeable. And I'm sorry, that's not a more definitive answer, but I would bet my honorarium tonight on it.
All right. Just as a side note to give you a little breather, we did place the handout. Joe placed the handout in the chat. For those who will get it that way, it will be also part of the post-event email. So Harvey, take a breath and go ahead.
All right. So now hopefully we're going to get some more feedback from Greg and Joe kind of asking me questions, because this is all the disease stuff. Okay. This is the procedures, diagnosis things, and legitimately, I can tell you about the coding and the billing types of things, that kind of stuff. I could talk about an awful lot of the technology, but the disease entity itself, if you ask me a question, I'm probably gonna kick it right back to the experts. So, but we'll see what we got here. So let's first talk about corneal and anterior segment stuff. So corneal topography, you guys are well aware, 92025. Believe it or not, this code is not that old. This code is only about 15 years old. It was, you would think corneal topography would be a very, long established thing. There really was not an awful lot of data showing the benefit of doing it. And that's where the codes are developed. And basically, it has to be not just that it's cool technology, it has to show that using the technology is going to change the treatment protocol and outcomes of a specific disease entity or surgical procedure. And that's why it has it. So codes out there. RVU, RVU stands for, that's the national valuation, okay? Medical necessity is a big issue here, and we'll talk about that later in medical necessity a little bit. Local LCD stands for local carrier determinations, often list them. Policies are again by private carrier. 92025 is not used for, they call it manual keratoscopy, which to me is a keratometer, which is actually defined as part of an E&M or general ophthalmologic service. So therefore, it would not be. Now, good, we'll come back to that. So one of the things that I've been seeing, we've been seeing across the board in audits is docs throwing corneal topography in automatically with their contact lens fit. Well, I think that's perfectly fine. If you feel that it's appropriate to do topography with your contact lens fits, I think, go great. That's wonderful. But if you're doing it just to see, what the base curves are and, whatever you're kind of doing, you're doing it as a screening thing or just giving you other information, that's not really treating a disease. So that's where we come to this whole concept of medical necessity. So again, Medicare and LCDs are developed for utilization of the conditions, and then medical policies by third-party payer. But medical necessity, again, the primary component of medical necessity and any of the things that we're going to talk about today really is, does it change the treatment, the clinical decision, or the treatment protocol that you're going to be doing? And that's really where it comes into those things. And that has nothing to do with some of the other insurance companies that are out there looking to try and not pay you because they say it's not medical necessary. That's a whole different conversation, but whether or not the diagnostic test is appropriate. Some of the new technology you guys probably are aware of, corneal wavefront analysis. It does allow for corneal and ocular wavefront technology there. The aspect, though, is there's no separate code for corneal wavefront analysis. I have seen people talk about utilization of 92015. I've seen which is refractive services. I've also seen 92025. It is not. You are not doing corneal topography using wavefront technology. There is not a code at this point. In those situations, if you're going to bill, you need to tell the patient you're going to be billing, you're doing something different. You should get an advanced beneficiary notification. That's be it whether it's a Medicare or a private pay patient, and then you can theoretically bill a 92499, which is unlisted ophthalmologic services. But again, those, and we'll talk this, I'm going to say this 1,000 times in the next couple, half hour, that it, if you do it, it's often not going to be covered, and you do need to file it with the claim information at that point. Anterior OCT 92132. Again, national evaluation 3210, medical necessity. Again, if you're fitting contact lenses and you're just doing anterior OCT, and it's not a scleral lens or it's not something else what needs to get the differential information, there's really not a medical necessity to do so. Can you measure corneal thickness with anterior OCT or corneal OCT? The answer is yes, you are doing pachymetry, but are you doing pachymetry, which is 76514, which is defined as ophthalmic ultrasound? And the answer is no, you are not. You're not doing an ultrasound, you're doing OCT of the anterior segment. So do not bill 76514, which is pachymetry, which is defined as corneal pachymetry, but it's also defined as ophthalmic ultrasound. So just a little caveat there. Again, patient, seeing, reviewing audits and reviewing charts on things where somebody's documenting, they're billing out the 76514, and they're actually using an OCT. Well, in most situations, I went the wrong direction here. Most situations, anterior OCT pays more than the pachymetry. The problem is the justification and the covered diagnoses may not necessarily be there on the 92132. The 92132 may not be there, so that's why they're using the 76514. Don't use a code just because you get paid for it and just because it sounds like it's a good one to use. Okay. External photography, again, in this scenario.
Hey, Harvey, can I ask a question? This is
Go
what I
for it.
kind of do, knowing that I can't, in a sense, get paid for the anterior segment topography, OCT.
Yeah.
But I have because I know it's more accurate, but I have my technician do both.
Yep.
She does a ultrasound on the center, and and I kind of use both to get what I'm looking for. Is
Yep.
it okay at that time to do the 76514? Because since I'm doing it,
as you're doing it, absolutely. Document why you're doing it. What's the justification? Create an order. Again, you have to have the medical necessity is also defined by clinical documentation of why you're doing it. Just saying order OCT or order pachymetry doesn't do it. Order because concerned with X, Y, or Z is your
so ocular hypertension is most of the time. So because of ocular hypertension. Yep.
Yeah, I agree. That's why I do pachymetry. We also see a fair number of keratocones also. So that's why I would be ordering it. And yes, in that situation, you can do one or both if appropriate, but you need to make sure the diagnosis matches what you're doing. If it's strictly for ocular hypertension, I would throw in the 76514. And yes, use your other data for it. Perfect example, and I know my associate's not in, on this webinar tonight. She does OCT of nerve and macula on all of her glaucoma patients. even though she can only bill for one or the other, okay? But she does because she's using the data, okay? She's doing it to make clinical decision. And I keep saying, why are you wasting the staff's time? And she says, because I need it for the information. And I understand that. So you're in the same scenario, Greg. Yes, you can do both. You're only going to bill one if it's only eligible. In your situation, ocular hypertension, OCT of the anterior of the cornea would not make sense for that aspect of it. Same thing with gonioscopy. You can't do gonioscopy using anterior OCT. It's a different definition there. You can use anterior OCT for narrow angles, but you can't use the 92020 code there in that situation.
Perfect. Thank you.
You're welcome. All right. So external photography, again, on here, couple things I want to go over on the external photography. Again, it's for purpose of monitoring and following patient's condition. It's not just for documentation. Okay. It's if you're going to be treating a patient and you're getting them better. Perfect example. I had a patient, it was right before Thanksgiving. It's a really scary situation, but patient came in, called me on a Sunday, eyes bothered them. They think that they scratched their eye. Sure enough, slept with a contact lens for 2 to 3 days prior, end up seeing, I stain her and she's got a nice dendrite, and I swear it's a dendrite, stains with the rose Bengal. I said, all right, get your contact lenses out. We treat her, see her the next day, comes in, she's looking a little bit better, still has the dendrite there, no question, this is not, whatever. Next day she comes back because her eye hurts her more. Sure enough, now she has a neurotrophic ulcer on top of it. Ended up going down to Will's for management because she went down really fast. Luckily, I did for medical legal, even though it says you're not doing it for medical legal, I did it for documentation of my treatment protocol. That's okay, because of the purpose of I was doing it for treatment protocol. If I see a herpetic lesion, I want to document and say, hey, I'm getting this patient better. That's really the conversation here. If you're just putting it down because you have a really cool corneal abrasion and you're not going to do anything different, you're going to have a bandage lens on because you're expecting them to get better, that's a different scenario. I find that certain corneal ulcers and certain corneal the viral issues like that, I like to document a little bit more because I'm going to be treating them a little differently and a little bit more aggressively. So you can do that way. Other parts here, as it says, specifically medical quality images must be or may be of digital Polaroid. That's how old the documentation was, or Polaroid, or SLR or equivalent. And that's by FDA and CMS. Now, why do I put that in here? Is because there are currently 7 adapters approved for use with smartphones, okay, for anterior segment. You need to be able to make sure that you are using something that is FDA approved. If it is not FDA approved, CMS specifically states you cannot bill it, okay? So just grabbing the eBay camera adapter does not meet the requirements unless it's FDA approved. There are several out there, as I said, so I have no problem with doing that, but just make sure that you are using something that's FDA approved. Is there, we all talk about the HIPAA police. Are the HIPAA police going to come in our office and start checking on us? The answer is no, there is no real HIPAA police unless somebody finds out that there's a violation, that you're doing something incorrectly, and there is no FDA police. The FDA, nobody's going to walk in your office and say, can I see the FDA approval for the camera device you're using at this point? That's not going to happen. But God forbid, you have a situation where somebody's doing a record review and you have somebody auditing your charts and they look and you can't justify where you got the photographs, that's where you become problematic. HIPAA also. I don't know if that's on the next line. Yes. Personal smartphone for medical images is a bad idea. Definitely get informed consent if you're using it. In our office, there are times where we're using digital imaging on a phone or on a handheld device like that. It is strictly limited to that office. It is not somebody's personal device. It is, it is just like any other piece of instrument that we have in the office. It is secured and it is wiped of any images afterwards. The images are uploaded to our server, so it's secure at that point. It's the only way that we can do it. Just be aware that those situations are out there and you do need to protect yourself. Some other blepharoplasty, just moving along the anterior segment here, blepharoplasty guidelines. At this point, there are only four carriers that have LCDs for blepharoplasty, and two of those have eliminated visual fields. So, guys as old as Joe, Greg, and I, the three of us, when we had patients that were getting blepharoplasty, we used to get referrals from the lid guys and the plastics guys all the time. Do visual fields with and without tape. Okay, you dill it, you do a 92083 or 92082 with a -76, you run it twice. That was the way you would do it. That being said, they don't apply anymore. Now, all of them include physical findings. So if the surgeon says, oh, it looks like the lid's coming down and off, that's basically it. They document the aperture, and that was the extent of it. Iridian, WPS, and Palmetto include photos with them. WPS and CGS do allow visual fields to be in there, but they're not required. So again, just some of the things, some of the younger docs may not realize, we all learn these things in school. You need to do visual fields with and without. Well, guess what? The insurance companies have gotten rid of those. Specular microscopy, 92286, anterior segment imaging. What we're going to jump on this one is justified, or again, medical necessity. Again, you're doing this specifically. There are only certain times when it's truly appropriate. You have a patient who has gutata and you're concerned about issues, be it glaucomatous issues, corneal edema issues going on that way. They're having a scenario where they have an you're putting in a secondary implant, and you need to make sure that the endothelium is going to be able to handle it. Previous ocular surgery, now requiring cataract surgery, aka LASIK or PRK, something along those lines, and then doing it. And again, if you're fitting a patient with extended wear contact lenses after ocular surgery, that would be justification. It's not eligible if the only visual problem is cataract. So if the surgeon is going to be doing cataract surgery, it is considered part of the pre-surgical evaluation to use, specular microscopy. All right, now some of the cool, again, the newer stuff that's out there talking about these devices is looking at corneal confocal microscopy, and what it is, getting really, really high resolution evaluations of the corneal nerve fibers. Why is it really neat? Again, for management of diabetic neuropathy, peripheral neuropathy, there's a high correlation between seeing these reduction in nerve fiber length and corneal sensitivity, looking therefore for risk for, again, neurotrophic keratopathy, and as well as, this peripheral neuropathy just in all the diabetics. Unfortunately, at this point, it is considered a 92499, an unlisted ophthalmologic code. There may be in the near future technology or device that actually specifically more towards it. And then at that point, they can develop a category 3 code. But again, it's not included in 92286, but these are things that we're doing at this point. 92071 is fitting of a contact lens, treatment for ocular disease. Again, this is putting on a bandaged contact lens. When they came out originally, it says to use either a 99070 or appropriate HIPAA code in conjunction with it. I have seen zero payers ever pay for the additional material on top of the service. I'm not saying it doesn't exist. I just personally have not seen it. We've had a couple surveys across the country, and we've yet to find a carrier that does. Again, you may have one, which would be great if you do. Even though the guidance says that they're supposed to be reporting it and you're supposed to get paid for it, unfortunately, they don't do it. Again, let's talk about medical necessity. Again, chemical burns of the ocular surface. Personally, I'm not that big on the cornea stuff. You guys may know, you may know more about that. I'm not sure I would be putting a bandaged contact lens on a chemical burn on the surface, but that would be fun. Corneal epithelial defects, definitely so. Abrasions are my primary ones. Postop care after pterygium services. Again, if there's specific reasons you need to do it, you put them on, but there need to be there. It's not just because you choose you want to. There needs to be those. But this is pretty cool that it has a pretty long and diverse list of different diagnoses. Now, this is not one of your questions, but this is a question that comes up pretty regularly. We see. This is a question that came to the Ask Coding Experts. It says, we filed a Medicare claim with a date of service July 3rd, 2022. In case you don't know, July 4th was a Monday. It was a Sunday night that day that happened on a holiday weekend. We filed a 99050 after hour services, 65222, which is a corneal foreign body removal, and a 92071 bandaged contact lens. Medicare denied the after hour service, and the bandaged contact lens says that they were included in the foreign body removal. This can't be right. Well, That is correct for Medicare. Medicare does not pay after-hour services. Just remember that. You know, it's a terrible situation that medicine is at this point. The only way that these services are going to be paid for additional services is if the patient goes to the ER. It's the last place you want your corneal patients to go. It's the last place you want most of our patients to go to an ER or an urgent care, because they're going to probably end up in your office a day or two later, you know, without the appropriate treatment initially. But Medicare doesn't pay for after-hours care. They do pay for urgent emergencies and things like that. Additionally, for foreign body removal, bandaged contact lenses considered a dressing is therefore included in the procedure. So in this situation, they build out after-hour services, corneal foreign body at 92071. What would I have done? I would have probably built depending on what the scenario was, if it was just a foreign body, if they came in and said something flew in my eye, then guess what? I'm using the 65222. If they came in and says, my eye's been killing me for the last 24 hours, I don't know what's going on, then I would probably use an E&M service on that data service, as well as the 65222 for the foreign body removal. But I still would not be able to use the 92071 because it's the management. You know, it's just what you're ending up doing. And again, this was the National Correct Coding Initiative, or the CMS guidelines. It says that you do not bill for it afterwards. All right, let's slide along now to 92072, which is fitting of a contact lens for management of keratoconus. And the key phrase is initial fitting. And it says for subsequent or follow-up visits, use a level 2 or whatever, use an E&M service or an intermediate level general ophthalmologic services. Again, report 99070 or HCPCS material code. In this situation, 92072, we do see payment from third-party payers for keratoconic contact lenses when you submit with the appropriate material codes. And that's through medical plans. Some vision plans will actually do it. If you happen to be participating with vision plans, that also can be there. What is included in 92072? The initial component is a slit lamp exam, diagnostic test, keratometry. You can do topography if you're going to do that. I mean, I do, and I recommend it. Looking anatomy, tear film, refraction. I put refraction with 2 stars on there because you obviously need to refract. And guess what? Refraction is not included in the procedure, so therefore you can bill it. I said, what should you do? Those are things that are in there. Assess the corneal shape, that's a topography. And then what are you doing? You're designing your contact lenses, the diameter, base curve, whatever you're going to do, corneal, scleral, hybrid, piggyback, whatever it's going to be. So in 2000, so the code came out, I believe, in 2015, maybe 16. I forget which year it was originally was out. And then there was a question about when is it defined as a new fit? If the lens needs to be changed because it no longer fits the patient's needs, the fitting of the new lens is considered an initial fitting. So if what would be an example of not fitting the person's needs? Well, that would be a refractive change. That would be a comfort change. That would be the lens riding too high, too low, too steep, too flat. Anything that's going on there. If there's something that's changing, it now becomes a new initial fit. If you're just replacing the contact lens for the following year, they came in, everything looks exactly the same, the acuities are good with the lens is fitting well, then that would not be a new fit. But if you're making other changes to the lens, you have to change the base curve, you need to change the diameter, you need to change the thickness or whatever it is, that does become a new fit. These are some of the HCPCS codes on there. I threw this one in there again, just even though it's 2 years ago, whether or not you're aware of it, there was a new code developed for the photochromic contact lenses. The only one that's on the market at this point is the AccuView transition contact. I think it's AccuView Oasis with transition, something along those lines. It's the only one that I'm aware of that's on the market at this point, so I can say that. Is that an appropriate lens for keratoconus? I would not think so, but again, that's still out there for you. Other ones.
All right, Harvey, hold on 1 second before you move on. Question rolled in. If the requirement for visual field is eliminated, will you be paid if you still do it? I guess, you want to kind of, see if the, defect is there, you raise the eyelids, may not be required for surgery, but can you still do it for a diagnostic to make the consult?
I think I understand the question. So the answer is you could, but again, are you doing it as a screening or are you doing it as a diagnostic? Remember that. If it's a screening to find out if the patient passes with the lid up, that's a screening. That's not a diagnostic component of it. Okay. That's making a clinical decision about whether or not the surgery is appropriate, but then it's not necessarily the surgeon would be having to do that, or the surgeon would have to write you an order for it. Then you're billing, you're not going to bill for blepharoplasty or dermatochalasis, most likely. You're going to have to put down for ptosis. And then at that situation, you could bill it in those scenarios. But if you're doing it and if you're sitting there saying, Mrs. Jones, I'd like to run this visual field test to see whether or not lid surgery would be beneficial for you. In that situation, I would say no, because you're saying, I want to see whether or not this would help you. Okay. But if Mrs. Jones has a ptosis and you want to justify, why you're referring them, I would say that would be okay. But you need to, it has to be more of the way it's being asked. And I think that's the fairest answer, Greg. And you know that there's a lot of this is semantics. I wish I could be more specific on that. But if you're trying to say, yeah, let's see if it does it, I would say no. But if the surgeon is saying, I want it done, then the answer is yes. You're having an order from an outside physician and you're documenting the patient has a ptosis that is affecting their performance. Okay.
Great. Yeah. The person that asked the question said, thank you. So you got to thank you. There's one that came to me as a private message here.
I won't hear it then.
It's just, you won't see it in the chat is all I'm saying. It's basically saying if the patient has a foreign body in the cornea and also a corneal abrasion, could you build a bandage contact lens for the abrasion and not for the foreign body? So, they have a foreign body and an abrasion. Can you do the bandage contact lens for the abrasion?
If it's in the same eye, I would tell you that it would be very hard to justify, even if you did have, this happen. We had one, and again, I had a perfect example of one the other day. My associate saw there was a contractor came in, swear to God, came in for routine exam, had pieces of just crap under his lid, was corneal abrasion on the one eye, and he actually had a piece of metal in his other eye. Okay, and he had zero complaints. Okay,
right.
In that situation, she did put she put a bandage lens on the corneal abrasion eye, took out the foreign body on the other eye, put the bandage lens on there on the corneal abrasion eye, and she documented the RT and LT, and she was able to get by that way. And I think that's the only scenario. But if it's in the same eye, you're going to be hard pressed, because I think the carriers are going to deny it. I think is the key answer. I mean, yes, there's two different diagnoses, because one's going to be corneal abrasion, without foreign body. See, that's where the problem is. You're putting in a diagnosis on the eye of corneal abrasion without foreign body, and then you're putting in foreign body. So you're putting down an ICD-10 that is contradictory to what you're putting down, even though you theoretically could have two in the same eye. You could have an abrasion in one spot and a foreign body in a different spot. It's very feasible, and I agree with you. I would kind of lean towards just doing the foreign body removal and documenting and treating it, because you're going to be, again, if you take out the foreign body, you're putting a bandage contact lens on, it's treating the corneal abrasion anyway. So again, think about the work that you're doing. It's not going to be applicable to do that. I would avoid doing it. Could you do it? The answer is, I guess you could. You could then try and appeal by sending your records in and show where the patient had the two different things in advance. Is it worth the $17 you get paid for the bandage lens? In my opinion, probably not. As well as the fact, you're probably paying your staff for all this time, which is going to be, you're paying them more than $17 an hour. And well, at least in New Jersey you do. And in that scenario, they're just going to be wasting your time on it. Sometimes you have to look at what's the act of least resistance. So,
right.
All right.
There's one more that came in here, and then we'll let you go on to amniotic membrane here. It says, if the keratoconic patient or the keratoconus lens still looks good the following year and everything is fine with the lens, what CPT code would you use? The lens fit and acuity are still being evaluated to determine the changes are needed.
Okay, I would be using a 92310 most likely. Okay, would be the most appropriate, which is a regular contact lens evaluation code at that point. That would be the most I would feel would be the most appropriate. Obviously, on top of your general ophthalmologic or your E&M service. So you're going to bill out a 92014, a 92310. You could, I mean, there are other levels of technician fits. If it's if it happens to be a scleral fit, you could actually use the scleral fit code also, if that's appropriate. But it's not going to be 92072 code in that scenario because it's not a refitting of the lens. So, but under most circumstances, I can talk about me, I can talk about other, docs in this scenario who work with them. I personally don't fit sclerals. I have another doctor who works with me who does. They still just use, if it's just a repeat, they still just using the 92310. If it's just reproducing it in that scenario, especially if you're not even ordering a different lens. I mean, if you're ordering another lens, you're still ordering the lens, you're getting your material benefit, and you're kind of just confirming that everything's doing okay that way. And you're billing out your service for your examination at that point. You're still most likely billing topography. You're still most likely doing whatever else you may need to be doing with the patient. But when it comes to just the fitting itself, I would be using a 92310 in those scenarios. Okay.
And you just got a thank you from Joanne who asked that question. So
no problem. All right, so let's jump over to amniotic lenses. So again, they still pay pretty well. One of the things, again, I'm going to go over here. Purpose here is, the Procera Biodisc, AmnioDisc are the primary ones that are out there. CMS reimburses for supply. Remember that it's included. Whereas other devices, other procedures we were talking about before, it says to bill additional, specifically in those two contact lenses we talked about before, the bandage contact lens and the keratoconic, it says bill separately. In this one, it's included. It's kind of like what happened with punctal plugs years ago, where originally you build this procedure and then you build the material, and then it all went into one. They raised the price on the thing, and then everything came in together that way. Other payers don't necessarily follow the CMS approach. One of the things that I want to put in here is that we every once in a while we get doctors that ask, we're getting denials for 65779. Well, 65779 is the one which is the sutured in one. It pays more, okay? But under most circumstances, I don't believe that there's any state in the country that the suture in version is allowed by optometry. I could be wrong. I'm not a scope expert, but I'm not sure that that's actually allowed by anybody. But they're billing it because the company said, here, use this, bill this, and that was what they did, and they really didn't pay attention to it. So just make sure you're using the right code is really what I want to talk about on that one. Covering conditions, chemical burns. This one, I truly believe chemical burns, amniotic tissue over as opposed to a bandage contact lens. I just don't think that an Oasis, AccuView Oasis, or the Night and Day, which are the two primary ones that people use, would be appropriate for a chemical burn. This, I think, would be more appropriate. Similar type of conditions as we talked about with the bandage contact lens, but obviously it's a much more complex procedure, much longer lasting, takes more follow-up on that aspect of things. Other ocular surface disorders, 68801, dilation of lacrimal punctal, with or without irrigation. With this one, if you're doing punctal plugs, do not bill 68801 because it is considered part of putting the plug in. Dilating the pupil with or without irrigation is actually considered part of the 68761. There is a national correct coding aspect that way.
dilating the puncta, not the pupil.
Dilated puncta, sorry.
That's all right. No worries.
Hey, you know what? If you use a big enough thing, or you you might dilate that pupil. Exactly.
You might be into the pupil if you're maybe have a bad hand. No worries.
Parkinson's is acting up today. Again, remember on 68761 that it's by each plug. CMS is so. This is a very confusing scenario. Punctal plugs. Some carriers want you to have it per eye, per line, per puncta, E2, E1, E2, E3, E4, putting it in as that. Medicare wants it with a bilateral. They want it 50, and that's upper and lower on the same eye or right and left, but they want a bilateral. I know that bilateral doesn't mean upper and lower, but that's what they mean. So if you're putting two on the one eye, it's still considered a bilateral. So just be aware of what your carriers are, what their policies are in those situations. Modifier QW. I wanted to go over this because a lot of people are using laboratory tests in their offices at this point. you do need to know what QW basically means that it's a test that you're using. It's a notation on your claim with your procedure that says that you're using a CLIA waive testing. You're a CLIA waived facility. You do need to apply for the CLIA waiver every 3 years. I believe it's $200 right now, $200 for a 3-year protocol. You do need to do it. So it's going to be a cost of doing business. You know, unfortunately, your reimbursements are not that high. What are the 3 primary laboratory tests that optometry are using at this point? 83516, which is looking, that's the lack of, oh my goodness. Yeah, what's the, I can't think what it's called.
Tier lab.
Thank you very much. That's a tier lab product that way. The 83861 is microfluidic analysis. Again, looking at different things there. And the 8780809, that's the rapid, I'm sorry, 83516 that's the inflammatory. I apologize. That's
Yes.
inflammatory. Okay, 83861 is your tier lab, and 87809 is your adenovirus or rapid RPS test that we'll be using for there. Now, I said before, you do need to go ahead and have this CLIA waiver. You can become a CLIA certified facility, but it goes to an awful lot of work. Okay, so most optometrists would not do that. Those are usually done in hospital-based facilities or somebody who's doing a lot of laboratory testing. Under most circumstances, every eye test that we have at this point is legitimately CLIA waived. Just make sure you get those and put the QW on there to let them know. Don't just put the QW on without being CLIA waived certified, because the government does check on those ones. All right, Greg, we're going to the next Q&A. Okay, so meibomian gland dysfunction. So, you know what? I may be out of order here. Can we go to poll 4 by any chance? Is that possible?
Absolutely.
Let's make sure I'm on the right one. I may have put this in the wrong spot. You actually should just take a look. Do you have the code, the ones that are in there?
Yep, this is number 5. I got it.
All right, I'm sorry.
No worries. It's all
Okay.
right. We're fine.
So if clearing a clogged meibomian gland with digital compression, what code would be appropriate? Now, again, this requires you to have some idea of what the category 3 codes are. And we're going to go over those category codes in a little bit. But if you're just clearing a clogged meibomian gland with digital compression, you're squeezing on the lid, what code would you use? An E&M code. 2 of these, I will tell you, are codes that are used for expressing the glands, and 2 of these are for diagnostic tests of the glands. And if you don't know, don't worry. Because if you do, again, you need to be something. I might have want to put this one afterwards instead of before, because if you don't know what the codes are, it won't help you, but we're going to go over them anyway.
So with that being said, we have about a 60%.
Okay.
I'm just going to end the poll.
Good.
And there's no other questions, Harvey, just so you know, we're caught up on the questions.
Great.
I'll end the poll. I'm going to share the results and you'll
Good.
see kind of what the trend
E&M
is.
code is correct. That is truly the answer. So if you're going in and you're just pushing on the eyelid and squishing out all the white crap out of there, it's just part of your E&M service. Okay. Just so you remember that. Let's go down what the codes are, though, what each of these are. So there are different devices that are out there, and these have been around for a while. Looking at ocular surface disorders, you're going to look at, if you're looking at LipiFlow, looking at the imaging of the tear film. LipiFlow is the primary carrier on this one, primary device that's out there. Some of the other companies have tried to have made similar versions. Again, Conan makes one. I forget, Opcon I think was making one. I don't know if it still is. But just basically looking at tear film imaging, when it goes to that's the 0330T, 05070 is near infrared dual imaging, simultaneous reflective and transilluminated light of meibomian glands. This is Lippis gland. Now, several companies tried to say they were doing this, and they actually got in trouble because they were not doing where it says dual imaging at the same time getting the reflective and the transilluminated. They were doing one or the other, or one and the other, but not simultaneously. So Unfortunately, Liposcan is the only one that's really doing this at this point. But those are two devices that are out there that are for assessment of ocular surface or anterior segment disorders. And, they are category 3. We talked before, category 3 codes may be reimbursed, may not be reimbursed. If you are going to be submitting to the payer, you need to document why you're doing it and what you're working with. Now let's talk about the therapy. Those were diagnostic. Now the therapy ones, clear, that is defined 0207T, clear eyelid gland with heat and intermittent pressure, LipiFlow. So again, for those of you familiar with the devices there, that's the one where you're putting the heat on and it's squeezing, going like that, okay? 0563 is evacuation of meibomian glands. So one specifically says clear eyelid gland. The other one says meibomian glands, using heat delivered through a wearable open eye eyelid treatment device and manual gland expression. That's a tear care product. That again is you're putting the heat on the eye and then you're expressing out of it. Again, the wearable open eye eyelid treatment, putting a Bruder mask on and then expressing does not count. It has to be an actual device that's doing it at that point. That's giving the heat through some other mechanism at that point. And then the guidance specifically says for evacuation of meibomian gland using manual expression only, use E&M service code. So just so you have those, these are things that we do in our office. I don't have a very, that's not part of my practice. My associate does use the tear care type product, and then she does an awful lot of just general expression at this point. So it's something to do. IPL, oh my goodness, everybody's talking about IPL. It's a great thing. You make a lot of money on these things. There's a big problem with it. It doesn't have its own CPT code, okay? There's a recommendation of using 17999, which is unlisted procedure, skin, mucous membrane, and subcutaneous tissue. It could be considered because there's no unlisted, but as there's no unlisted value, you most likely, you're gonna have to submit some type of documentation, kind of as if you did the 92499. I can't ask a company to make a code proposal, but it would make optometry and ophthalmology's life so much easier if they did. Or you have to do it in a scenario where the patient is being advised in advance, this is not covered, and therefore you are responsible for paying for it. You need to sign a document in front of which, but just expecting that the insurance companies to pay it is really problematic at this point. It's just one of the things that we run into. Corneal cross-linking, certain states are starting to be able to do this at this pack. Removing corneal epithelium, Pupilometry. What is important, what's new with this is that you do report their medication separately. Again, it's been around for a while. Give me a second. My lights in my house just turned off because it's 9:30. I usually go to bed by 9:30, so let me just turn them back on. All right, a little bit better there. All righty. So, again, just basically saying to use it. Lens autofluorescence. Haven't seen the device around in a while. It came out a couple years ago. Again, checking for different types of physiologic and pathologic conditions. The scenario with lens autofluorescence is, again, it was considered part of the general ophthalmologic or E&M services. There really isn't a code. But if you happen to purchase one of the devices, again, be aware that you're going to be using a 92499 would be considered. But again, you're going to have to deal with documentation on it. I want to jump ahead. Here you go, Greg. You guys wanted to talk about glaucoma. Let's talk about glaucoma. I'm going to go through this stuff kind of quickly. Things to remember: mild, moderate, and severe when it comes to staging. This is stuff that ICD-10 that we talked about. Actually, this was back in ICD-9, and then it kind of transferred over to ICD-10. And in that scenario, it was based solely initially on the visual fields. The new guidelines actually include optic nerve changes also, but I'm going to go about staging mild, moderate, severe. When it came to CMS and ICD-10 and staging, they were sticking still in the visual field. Within the profession, within the Glaucoma Society, they are actually talking about optic nerve aspects also. So again, here looking at it, patient has no visual field. The second, a moderate visual, it has optic nerve abnormalities consistent with glaucoma and a visual field within one hemifield and not within 5 degrees of fixation. Severe is obviously more advanced. It goes within the 5 degrees, both hemispheres. And looking at those things. Why is it issue? We're going to show this in a little bit. What kind of things can you be doing? Well, Greg already talked. You talked about using Pupilometry. for optical ultrasound pachymetry. It's once in a lifetime or once per patient for glaucoma that varies by payer. Why do I say that? Because you know what? We all have patients that we have glaucoma that we're treating who we want to know their what their pachymetry is, and they've had it done somewhere else and it's been denied or it's paid. Legitimately, I have had 0 times where a patient who I know has had it done before, but I can't get the records and I really need to know for treatment protocol, it being denied. It's supposed to be once per lifetime. That being said, most payers are doing once per patient. Gonioscopy, you need to again remember it's a bilateral procedure, whether the patient's monocular or binocular, one eye or unilateral, uniocular or binocular. You have to have an order and interpretation report. And I put down yearly. We're going to come back to that in a second. Fundus photography. Again, it's if you're just documenting the optic nerve, that's not it. But if you're documenting for consideration of treatment protocol or changes in the disease or changes in your therapeutic management, that would be why it would be good there. It's typically yearly or significant changes. So I had the gonioscopy. Gonioscopy is probably the least, and again, you're the glaucoma guys, is probably the least utilized, one of the more effective management tools that we have for glaucoma, and it's payable on a regular basis. I basically, when I talk about practice management to doctors, I talk about developing some type of a treatment protocol, billing protocol, where their examination, they're going to do an examination, and at one of the visits, be it the initial or the 3-month or the 6-month or the 9-month or whatever they do in those situations, that we say do gonio, unless the patient's pseudophakic, and then even those pseudophakic patients do change, but most patients that are phakic, there are going to be changes in the drainage system that you will be able to pick up, be it the angles getting a little narrower, pigmentary changes that are in there, especially as these patients get older. So I think it's a very underutilized, undervalued tool for there. So again, you guys feel free to throw in your 2 cents, but I'm still talking. All right. So
No, I believe, no, Harvey, I'll give you time to inhale and exhale is that, I believe that that should be done. And you hit it. I mean, even if they're pseudophakic, not all surgeons are created equal. You can start get pigmentary changes, and you might see why you're starting to see some of these changes. And on top of it, a lot of these times the surgeons are doing these MIGS procedures, hook dual blades, and so on and so forth. And you just kind of have to see what's going on. I agree. I'm sure Joe will weigh in. He does a lot of record reviews and he does a lot of, testifying. It's just totally underutilized. And one of the clinical pearls that I always, say that, when I got good at gonioscopy is whenever I was working at an ODMD place, and at the 1 week follow-up or 1 month follow-up, for 1 month, I just did it every day and didn't charge for it, but I wanted to get good at it. Then I was able to evaluate the glaucoma patient. So I think it is one of the most underutilized that's out there. But, give Joe a little second to weigh in there on that and look at this question that just rolled in.
Yeah, it is underutilized, and people think that it's like pachymetry one time only. And when somebody's phakic and you have cataractogenesis, you can get into relative pupil block. I probably have a patient or two a year that go from an open angle to a potentially closed angle, or at least an angle closure suspect. So it does have to get repeated occasionally. It's also underused in ophthalmology. I was at the World Glaucoma Association meeting one year, and that's more for that's really more for general ophthalmologists. And the glaucoma specialists who were lecturing the audience kept imploring these people, like Greg said, just do it on every person till you get good at it. And that was to ophthalmology. And I also remember one glaucoma surgeon, Dave Greenfield, who made a comment. He said, in ophthalmology, the first time they usually do gonioscopy is when they're doing the SLT.
So Tim and I are on the same page here. Just wanted to make sure that I'm fine. I probably 50% of my practice is now glaucoma. I saw a bunch of glaucoma patients today. And you talk about ordering the tests. So I did as my plan, return in 4 months. I'm going to check IOP, do gonioscopy, and a visual field 24-2, see the standard SS fovea on. Is just writing it down in the plan, gonio, is that considered an order?
So again, I did allude to this earlier. So you need to document why you're doing it, not just that you're doing it. Okay. So return for gonio, repeat or do gonio in 3 months to check for angle, precession or whatever's going on, due to pressure being elevated. Return to visual field to confirm no changes on medication management. There needs to be something there beyond just order gonio, order sensory motor exam, order OCT. It has to be why you're doing it. And it can be as simple as, like I said, just to check for progression. You're allowed to say that, but there needs to be a little bit more for that. Okay.
Perfect.
Cool. All right. What we're going to do, I'm going to probably, because again, I know we probably have about 7 or 8 minutes before we got to wrap these things up. I'm going to kind of skip through some of these. I'm going to jump to the important slides. So again, everybody knows about
while you're doing that, we got a question. It says your slide says not to do visual field with 92134. Isn't 92134 optic nerve OCT?
Okay.
I
good.
do.
I'll
I
jump.
think that's
Oh,
retina.
it
is 3-4. Go ahead.
Okay. So the reason that it is, so it says do not perform 92134 in same data service without good reason and need a MIF 59 modifier. So there were payers that were actually saying that the 92133 and the 92314 were giving similar type of data and similar type of information that you were gathering with the 9283. The AMA, or the Academy of Ophthalmology, was able to argue that the optic nerve changes in the that were being picked up by the OCT were not the same as the visual field defects that were being picked up in the in the 92083, but they were not able to argue the same for the 92134 was the issue. Okay, so it was just strictly because the 92134, if you're doing macular OCT and you're looking for what's a GCA, ganglion cell analysis, ganglion cell dropout, that would correlate directly to the visual field defect, if that makes sense to you. So that was why they said they couldn't they couldn't get it there. So it was an issue with it's a payer issue more so than a utilization aspect. Okay, if that kind of helps make the answer. The 92133, the optic nerve OCT doesn't necessarily show the same information that the visual field information would give, but the retina scans did. All righty. All right, let's go forward a little bit here. So I do want to, okay, so again, we talked about anterior OCT. Other kind of cool ones that are out there, corneal hysteresis. I don't have the device. It is definitely something that many docs who are involved with glaucoma management are looking at, utilization on it, corneal hysteresis determination by air impulse stimulation. There are no utilization guidance or LCDs. It doesn't reimburse very well, but it does help guide some of the information there. There are signs that show, there are studies that show that that low corneal hysteresis correlates to visual field defect, optic nerve damage. So again, something to take a look at there. Another one, which we learned about years ago, 019AT, which is ocular blood flow. With this one, again, it's not often paid. The technology is there, but the problem is, again, this has been a category 3 code for about, again, I'm going to go 12 to 15 years, 13 to 15 years at this point. The problem with it is that even if we know it, it's not changing. We're measuring something, but we're not changing our treatment dependent upon it. There are so many other things that are more valid for guidance treatment. That's why there's no category 1 on there. Just be aware that there are remote visual field technology. This was kind of cool. What diagnosis, this is a non-poll question. What diagnosis demonstrates medical necessity for visual field testing? I have macular degeneration, glaucoma, diabetes, peripheral retinal disease, strabismus, myopia. There should be a question on that. It is. And basically the answer is all of them. Okay. There need to be. Now, again, you wouldn't be necessarily using a 92083 for macular degeneration or strabismus, but you may, depending on what's going on there, if you're finding there's essential scotoma, that there may be some type of arcuate defect that's going on from these other retinal conditions, that you're going to actually be on there. We had Maria had one of our low vision patients today, was told that she had a hemianopia. Maria had the patient do a visual field. Patient's field looked like crap. There was like a 5 degree of functional vision on one eye and maybe 12 degrees on the other eye. But she did not demonstrate a hemianopia. And I said, this just doesn't make sense. And we then took a look we dilated her, took a look, and sure enough, she had PRP everywhere. She had advanced diabetic retinopathy, she had a lot of retinal changes at that point, and they just burned the crap out of her eye. Somebody had just told her that she had a visual field loss due to a stroke, which she did have a stroke, but it had nothing to do with her field loss at this situation. So again, there's reason to do that. Back to utilization guidelines here, important component here. On the right-hand side where the right X is the utilization of let me just make sure that this is the right one here. Okay, OCT. Patients who have severe, we talked about mild, moderate, severe staging of the glaucoma, should not, I know this sounds silly, but should not be doing OCT. There's several different clinical studies that show that the utilization of OCT in advanced glaucoma do not show enough measurable change on the OCT, and that visual fields are much more appropriate and should be done up to 4 times a year is what they're saying on that one. On here, they're recommending every 4 to 8 months, but it can be done up to 4 times per year if needed on those patients. Good. Here's a question. You get this one? This was question number 3.
Okay, I'll get it for you.
Yep.
It's been launched.
Okay, good. So when performing OCT and OCTA on the same day, what codes are appropriate? 92134 and 92012, 92134 and 92499, 92134 and 92212, 92499 only, or 92134 only. Again, you're doing OCT and OCTA on the same day.
And you got a bunch of thank yous for answering the questions previously. And just for the time, I will end the poll.
Well,
I will share you the results.
thank you, sir. All righty. So the official answer would be 92314, which is the last one, which most people got, which is great. In that scenario, I'm going to explain to you why each of those. So first of all, at this point, I'm going to hit close. We'll go through this real quickly. Okay. So if you're doing OCT, first of all, this is a preemptive conversation. 2024, there will most likely, again, no guarantee, there will most likely be some changes in the way that you're going to be seeing your OCT codes. Okay. I'm not talking about reimbursement, just the way they're defined. Okay. I saw what's happening and the discussions going on. They're making some modifications to it. So that's the headline there. That's why I wanted to go ahead of these. We talked about severity aspects of there. Okay. Again, this talks about utilization of 92133. CMS guidelines say 2 exams per year for patient who has suspected glaucoma. LCD state once per year for pre-glaucoma or those with mild, 1 to 2 tests for moderate staging, advanced staging. 92134 is for retina stuff, macular degeneration, diabetic retinopathy, and glaucoma many times at this point now. 1 exam per eye every 2 months for patients with disease. And then if they're being treated, you can do it once a year. Now, ganglion cell analysis, I just talked before about for glaucoma patients, 92134. Again, it isolates a ganglion cell layer. That would be an opportunity to do it. If you have a patient that has glaucoma tissue or optic nerve disease, that would be a reason you would put down 92134 for that patient, and it is covered by many of the insurances. I'm going to skip by VEP, go to that. fundus autofluorescence. I know I'm coming to the OCTA thing. Don't worry. I know where we're going with this. Fundus autofluorescence is another really cool technology. If you have it on your camera at this point, taking a look at autofluorescence of the eye, whether or not it's checking the how much transmission is going on here. This actually was a picture I took 2 days ago. Today is Tuesday. No, it was on Saturday of one of my RP patients. I thought it was the coolest thing. I mean, there's just no reflectance whatsoever. There's no RPE on the patient. Okay. What it's good for is looking for photoreceptor damage, light sensitivity. Hyperfluorescence causes the light to come back. Hypofluorescence is the RPE cells are dead. And again, like I showed you just in that last picture, patient has nothing out in the periphery at this point. Spectrophlogography, again, looking for central retinal vein occlusions, again, new technology. Okay, so let's go here. This is why I wanted to talk about this. Angiography software, OCTA. It's non-invasive, dialysis, high resolution, 3D. At this point, your choices would be using a 92134 or 92499. On my question and answers there, or my questions I provided before, I said 92134 and 92499. You can't use both. You can't do the two together because you're doing the same technology. That being said, again, pay attention in 2024. There is a high likelihood that you will see a new OCTA code coming down the road. I don't know for sure, but again, it is very likely. I know that it was applied for. Let's put it to you that way. And, depending on what CPT comes out with, so what would end up happening with the new code would be you would have to do regular retinal OCT and OCTA on the same day, and it will be billed as one procedure with the valuation based on the combination of things. If that's where it goes, that's what we're expecting to happen. Again, we'll have to see what happens as we go along there. But I wanted to let you know, this is part of why, I'm glad that, Greg and Joe asked me to do these things. So these are things that you're going to hear. Like I talked about that vision therapy stuff last year, knowing where it was going to come. Sitting at the table, we see a lot of these things happening. You should have learned also at this point about the ophthalmologic services, extended ophthalmoscopy. They changed. So you're looking either at an anterior segment, or excuse me, optic nerve or macula or periphery. With that, remember, if you are doing extended ophthalmoscopy, periphery, you must do scleral depression. Okay. I'm going to get out of here. This was another question. You don't even have to put it up. I'm just going to put it here. When using wide field retinal screening, what is the appropriate code? There are 4 codes up here. I'm going to just jump ahead on this one because we need to get along with time. Basically, you're just doing screening. Retinal, you're doing an Optos or a Zeiss wide field screener or any of the other companies that are out there. Yet you should be using an S9986, which is not medical necessary service. If you happen to find something and then you feel that you need to document it better, you can then create your order, just as we talked before. Patient found, retinal detachment found, order fundus photos. Take your pictures that you need at that point. Don't use the same Optos or same visual field that your photo that you did before because that would be justification. Then you use the 92250. But if you're just doing screenings, it's not appropriate to use the 92499. It is appropriate to use the other ones. We're going to get rid of this one, get rid of this one. So I really want to jump to the last little bit here. Get out of this. Okay, good. Last little bit and we'll wrap it up. There are 4 new surgical codes, which you do need to be aware of. Cataract surgery. You're already aware of 66982, which is with the cataract surgery, the complex type. That one we've had there. They added some changes. At the bottom, you say without endoscopic cytophytocoagulation or ECP. They created a new code, which is, again, complex cataract surgery, but with ECP done on the same day. So ECP is a protocol or a treatment option for affecting the ciliary body, which therefore reduces intraocular pressure. So it's a combination of cataract surgery and glaucoma management on the same day. Additionally, another new code was developed, which was complex cataract surgery with the insertion of intraocular anterior segment aqueous drainage device, such as an eye stent, as you see in the bottom picture, okay? If you're doing the cataract surgery and the eye stent type or some other type of device, the Zen gel and things like that are not, those are not an anterior segment aqueous drainage device without extraocular reservoir. It's specific to that type of device. Then you would use 66989. Again, same component applies for the Standard 66984. If they're doing without endoscopic, with endoscopic is 66989. With with some type of a surgical procedure for drainage at that point, that would be 66991. If the surgeon is doing the drain without the cataract surgery on the same day, which is becoming more prevalent, and it's, there's an issue with FDA approval and things like that. In those situations, it becomes 0671T. There was also a new code, as you may be aware of, 68841, which is insertion of drug-eluting implant, which is Dextenza. It was the only medicine that was approved to use this in this scenario. We're hoping that other ones will become out there sooner. In that situation, you're putting punctal dilation when performed, you're putting the implant in there, and that would be used. That's primarily being used for cataract patients, as you guys are probably aware of at this point. Don't worry about that. YAGs, we're going to skip over at that point. You guys survived, and I did it there. So please ask additional questions.
Harvey, great job. We're lucky to have you, your team, in a sense, AOA's team, you, Rebecca, and Doug, to really kind of monitor all this stuff. One of the things when people do these talks, they create fear mongering. It's one thing that I really love that you've done over the years. You do not go out there and create that kind of fear mongering, and you're going to get arrested and you're going to do this and do that. So you're clearly an expert in this arena. And Joe and I were super lucky here to have you tonight. So great job. I don't see any other questions rolling in here. Joe, do you want to make any comments before we wrap up the CE?
I just want to echo what you said, Greg. I think this was terrific. We really appreciate having Harvey to be able to do this, because this is not our forte, but we do want to bring other things to our audience. So this is really wonderful for you to do this. Thank you.
You're welcome. I'm going to just go. There was a question there. What code for multifocal IOL? If you take a look on the one, there was one slide that talked about all the different contact lens codes, the HCPCS codes. You can actually do that. So you can actually see it. I don't have it right in front of me at this point, but you guys, I truly appreciate it. It's been a while since I had a good opportunity to communicate with you. So I truly appreciate it, and look forward to talking with everybody again in the near future.